Well, good. Don't all speak at once. Hopefully you all have some thoughts to share with us. We know one of the issues going into this expansion is going to be provider capacity for our residential programs. That's something we're certainly working on right now to try and um, ensure that we have enough residential providers to meet the needs of um, the expanded population. So that's certainly something on our radar. Are there some other things that we need to be considering as we expand this waiver? Megan has asked, can I talk more about workforce efforts? In terms of general workforce efforts, I am certainly not our expert. We have our workforce team that's really working on a number of efforts trying to increase workforce in terms of provide trainings, portable trainings for those caregivers. Karen, I am blanking on some of these workforce efforts, but we have our whole team dedicated on those efforts. And I'm just not the expert on those.
Yeah, I'm not either. I think that's certainly something we can continue to promote with our information that we're putting out, and it's certainly on the radar. As far as specifics, I don't know that I have a lot to add either.
Okay. And there's been a couple of questions about what exactly are we talking about in the expansion. So let me give a couple of introductory sentences on there. So, Karina, can you put the link to the memo in here? So we have received, there was legislation that was passed telling the department to include into the CHRP waiver an expanded eligibility to help individuals, children with mental health concerns. So what we are doing is we are expanding the CHRP waiver. In addition to those children with intellectual and developmental disabilities, we're expanding that to the population of children diagnosed with serious emotional disturbance. And so those children will also be able to be served under this waiver. So it is hitting those two dual populations now. Let me hand it over to, I think, Pam, your hand was first, if you'd like to go ahead.
Great, thank you. And I think just following some of the chat conversations, as a provider, this is probably one or two preliminary meetings that we've been exposed to. So when you ask for input, it's kind of hard because we don't still understand the parameter of what this is or the why. SED is such an archaic and possibly offensive label as well. So I guess one question would be, is that SED language staying in there, or will it be updated to better meet the youth's needs of definition? And then what does that entail? I mean, what kind of diagnosis is that? I'm with Shiloh, and we're a QRTP provider as well as a respite provider, and we see lots of different ranges of youth kind of come into our services. And so, and many are acute. So we're just trying to figure out, what does this mean? Would some of our current clients fit this? What does it mean if they do? And how do we need to apply to be under this waiver? So I guess I think as providers, we're still kind of lost in what does this mean? So it's hard to give input when we don't understand the whole being of it. And just, yeah, does HCPF already have a definition of what diagnoses or what it would equate for? Thank you.
Good questions, Pam. Yes, that definition, we'll share that with you. We can put it into the chat so you can see exactly what that means. The name is staying. That's the name that the serious emotional disturbance is what we'll be using. You do not have to also have an IDD diagnosis. So it's going to be either or. So a child could both certainly have an ID diagnosis and SED, but they don't have to have it. They could just have that. And so you don't need to do anything as a provider agency in order to accept children with this diagnosis. It will just be this additional cohort of children will be able to be served on this waiver rather than having a different waiver or something like that. It will just be more kids on the CHRP waiver. Karen, will you work on putting that into the chat? And then I don't want to read it out to you, but we'll put it in there what that definition is.
Yeah, I'm pulling it.
Thanks. I think there was someone before. I think Elaine, you had your hand up. Elaine Wood, you had your hand up next.
Hi, good morning, everyone. Actually, it's Danielle and Gotti. I'm Elaine and I work together and she registered us and it wouldn't let me change the name. I apologize. She's also on here. My question or concern in regards to this waiver is that this is a waiver that a lot of youth with IDD use and then step onto the DD waiver. And is that now going to be taken away from those youth? And then I am really interested in really understanding how the state plans on working on this expansion for the fact that, as you know, the ARCs predominantly heavy advocate for individuals with intellectual developmental disabilities, and they are a class of population that really struggles to get support. And so if we are now opening this waiver up to anyone who potentially qualifies under this, I'm concerned that we're giving up beds to a population who heavily needs it, when there's already not enough beds for that population. And now we add this, and then how do we navigate the system for all the kids that are already on CHRP expecting to go on to the DD waiver who do have IDD? And what is that roadmap going to really look like? And expanding it to improve for one population, are we going to cause a crisis for another population? And I'd really like to hear the state's proposal on how they're going to mitigate any more damage to that community.
Well, those are good questions, Elaine. I will say, as Maureen put in the chat, that she did request we have this conversation to better understand some of the concerns, current issues that are happening with CHRP. So we aren't prepared to answer all of these questions today. So really more want to hear from you what those concerns are. I will say that if a child does not have an IDD diagnosis, then that does not mean they get to move on to the DD waiver. So there's not a spot on the DD waiver that they're taking, but we certainly hear you that we don't want to create more problems for kids currently on the CHRP waiver because we're adding this new population in. So we absolutely hear you about that concern that taking away beds from kids with an IDD who need this. So absolutely hear you on that, but we're not prepared to speak to it. We don't have a department stance or a statement here that I can share about the rest of the issues that you raised.
And I saw Maureen's comment in the thing, and I see that.
Maureen,
But just as
yeah,
I just wanted to see if we had thought about how that affects it.
yeah, absolutely. Thank you, Elaine. Maureen, you want to go ahead?
Can you hear me okay now? Okay, perfect. So I have quite a few because I was the one that requested the department consider having an open meeting like this. So I really appreciate all of the staff that are here right now. But like I said in the chat, I do believe today was mostly to address the current issues with CHRP. And I've been a CHRP cheerleader since day one. Back when I taught transition age students at Project Search at Children's Hospital, I had 18 to 21-year-olds. This was back in 2011. Yeah, I've been around for a while. 2011, individuals had to be in foster care in order to be on the CHRP waiver. So yeah, we've come a long way, and a lot of people may not have been around that long. Some of you have, I know, see a lot of good names here. But now we have CHRP expanding to individuals whose parents are still in their life. They still retain parental rights. Back in the old days, you had to surrender your parental rights to get on the CHRP. So just like everything on the waivers, it's always evolving. I just want to point out that I know a lot of families who have transferred from CHRP onto the CES because of mainly provider issues and rate issues. So that's really what I wanted to address today, is to point out the disparity and some issues that I think the department could take leadership on and try to create more equity between, so that we don't have this issue of two statuses. Right now, when you're on the CHRP, you don't have access to the same menu of services that I think those members really need, especially now that they are not always living in a foster home. In the past, just like on the DD waiver, the foster care per diem captured a lot of services. And now we have that same population living at home in the home and community, going to school, and they need more services that are like the CES, if that makes sense, because they're living in the home and community with their families and not a foster care provider. So the first point that I have is that we have a dearth of PASA agencies that are willing to serve the CHRP waiver. Currently, right now, there are only 3. I just checked the list. There's a 4th one that recently joined, but I'm not sure how wide they're offering their services. For the wraparound, which is called ISS, Intensive Support Services, and also the Child Youth Mentorship. This is a real issue. And one of the reasons why we have so few providers is a business reality. We don't have a lot of kids on CHRP. So I think we have an opportunity here to motivate more PASAs to get in the business of serving our CHRP community by increasing the rates and also making the 2 waivers more equitable between the CES and the CHRP. So my first one is the rates for wraparound need to be higher. Right now, the ISS role for wraparound, it is wraparound, but we call it ISS and CHRP. Sorry if that's confusing people, but it is a very skilled role. Some of the best wraparound providers I know are actually MSWs or RNs. These are people that could make a lot of money with their degrees, and they're choosing to serve our community. Right now, they're not being paid enough. That would be A. B is that PASAs are unable to source the child youth mentors once they do get a child into their services because they're paid like unskilled respite workers. Just as a comparison, the child youth mentor on the CHRP waiver gets $8.11, and this is before the agencies have overhead for 15 minutes. And the respite for CHRP is $7.20 for Denver residents and only $6.82 for non-Denver residents per 15-minute unit. So you can see that the child youth mentor, they implement the goals of the wraparound provider. And they're a little bit like a paraprofessional and a teacher, for example. Okay, we got to professionalize this because those are the people that have more hours with the client than the wraparound mentor or the wraparound facilitator. So we need to look at the rates. Also, respite is useless in CHRP. We have the highest behavior children, youth, I should say, and we're paying them the least. There's an inequity between the CHRP waiver. Right now, the CHRP respite for Denver is $7.20 for 15 minutes in Denver and $6.82 for 15 minutes in non-Denver. And the CES is significantly higher. The CES waiver for respite pays $7.59 a unit for Denver and $7.27 for non-Denver. So respite really needs to be paid more like community connector because these are the highest behavioral children. We need to be paying those people at least $25 an hour after the agency takes their cut. And because they're more behavioral, we can't do this workaround that's happened in the CES waiver where a lot of people are contractors working for PASAs as independent contractors. I never recommend it when we have a highly aggressive youth to use a contractor because injuries are almost inevitable. We need the W-2 protections for workers' compensation. And the only way to get people to work is to raise the rates so they can be a W-2 employee. All right, and then I'm just going to go to general services. There is inequity between the CES and the CHRP. And because these youth are living in the community, we need to really look at this. Community connector in the CHRP waiver right now is capped at 2,080 units per plan year, which is 520 hours. And there's absolutely no cap in the CES waiver. Okay, that's a huge inequity. Also, that happens to be the amount that a parent can actually bill the CHRP waiver for their own parental provision. So if a parent uses that 20 hours a week to take their youth in the community, especially in the summertime or school breaks, they have no community connector left for a non-family member to take them in the community. That's a huge restriction when we have children who need to build skills, and community connector is about building skills. Also, the community connector in CHRP is lower than in the CES, which doesn't make sense because we have higher behavioring kids. Denver County CHRP community connector is $11.87, and For CES, it's $12.36. That doesn't make any sense. On the CES, outside of Denver, Community Connector is $11.49 and CHRP is $12.03. So anyway, that's just an issue. I have two more, then I'll let someone else speak, I promise. There's no group respite on CHRP. This is a huge problem. Megan's Place, an amazing PASA in Wheat Ridge, is open to serving CHRP youth, but they cannot serve CHRP youth because there's no group respite on the CHRP waiver. And when we're looking at children that need after school care so parents can work, we need to open up group respite on CHRP for, and it should be an open dollar amount like it is in the CES up to the individual respite amount. We shouldn't have it capped off. We need to keep it flexible for the provider. And then my last point is that the respite rate for this population needs to be higher because otherwise it's a useless service. The adult waivers have levels of care differences of pay. And this is going to be even more critical as we get into that expansion time. And we have children with more behavioral issues. The CHRP right now is $7.20 a unit for Denver, $6.82 for non-Denver. It's significantly higher on the CES waiver. It's $7.59, so 40 cents higher in Denver on the CES. And then it's almost 45 cents higher for between the CES and the CHRP when you're not in Denver. So those are my inequities. I'd be happy to email them into the department if you tell me who to send it to, Cassandra, because I wrote it all out. So I know that was a lot of notes to take, but I do think that just a little bit of a change of philosophy happened when we moved from requiring the county to have custody of CHRP into a community-based waiver also, and we never adjusted the services to do that. So adding the group respite, adding in more equitable community connector, and then also reevaluating the rates for ISS and the child youth mentor. We need to raise the bar so that we get more PASAs getting their staff on board before the July transition. Thank you so much for having this meeting, and I'm open to taking questions.
Thanks, Maureen. I think that's helpful. I do agree with you that that's been a pretty big shift from one philosophy to the another, and having that really be more of a community-based service rather than needing it to be foster care or you know, it's families still taking care of their kids. So appreciate all of those. If you can email them to me, it's Cassandra.Keller. I will take all of those notes and we'll work on those.
Great. And then also I forgot to say at the beginning, you said that you were looking at capacity issue for residential placement. And I think that actually the capacity issue is beyond residential placement. It's for these community-based services. So I want to make sure that we capture that today.
Yeah, very fair. And one of the good new things is that part of our budget that was put forward last week and issued, we are asking to have that group respite rate be within the CHRP waiver. So that is certainly something we are seeking to do this year.
And would it be up to the individual rate? Because they did not do that in the CES waiver for the that was the other thing is we don't have the youth day services in the CHRP waiver either. So the youth day services, they did not do it open to be up to the individual group rate. So that's where the disparity is in the CES too. And I brought that up in different meetings to HICPUF, but the youth day services are really important too to keep parents working.
Yeah, I don't know how the group respite rate was exactly calculated. If it goes up to the individual, but we are at least asking so that we can get that also in that waiver.
Yeah, make sure it's up to individual or it won't be taken. So that's what I'd encourage you. I'll take a look at that document. Thank you.
Thanks, Maureen. Terry, you've got your hand raised. Terry Walker.
Thanks for letting me talk and having this session today. First, I would just like to say that I agree with absolutely everything that Maureen has been saying today. I'm a parent. My daughter is 16. She's on the CHRP waiver now. She has IDD as well as mental health issues. We adopted her through foster care about 3 years ago. And she actually got on the CHRP waiver not through foster care, but after she was adopted. So it didn't have anything to do with her foster care status, but she does have a lot of behavioral concerns. And I thought I'd just maybe give a few examples of a situation, you know, from my situation to help support some of what Maureen has said. In terms of provider capacity, the first year that we were on the CHRP waiver, we didn't have respite. We didn't have child youth mentorship. We didn't have Community Connect until Maureen helped us to realize that my husband could do Community Connect for her. So essentially the only service she had the first year was music therapy. And we struggled to find providers. We've had 2 respite providers more recently. One had to quit because of scheduling difficulties with school, and the other one actually ghosted us shortly after our daughter had her first meltdown with this respite provider. And so, you know, like the behaviors are a concern to providers. They don't want to deal with the behaviors at those lower rates. We need people who are more skilled and who have who will get paid for those skills that they have. Let's see if I'm looking at my notes. Sorry. And then I've also heard, you know, we actually had music therapy before we got on the CHRP waiver. But we couldn't stay with the same music therapy provider because they get paid almost twice as much in the private sector as they would get paid through the CHRP waiver. And then Community Connect has been one issue. My daughter, she, I guess, got lucky and got audited. Her file got audited for Community Connect. And it was, we discovered that we don't get to work on the same skills in Community Connect, that the Community Connect happens in CES. So like learning how to navigate your environment, like people on the CHRP waiver can't work on that particular skill. They have to work on just behaviors. And if you, and like, I went and looked later at the actual waiver and the language in there, and it's like, it's just about like behaviors, and it's like very extreme behaviors, like exposing oneself and, you know, like being aggressive towards strangers. And I think a lot of people on the waiver, like my daughter, their behaviors don't necessarily manifest in that way. My daughter's behaviors mostly manifest at home with her parents. And however, experiences that she has in the community, like difficulties navigating her environment, difficulties interacting with strangers, she holds it all in, she masks, and then she comes home and explodes on me and my husband. And so we need to be able to work on those skills and build those skills in the community, even though she doesn't expose herself in the community with things, you know, things like that. And then my last point, sorry, thank you for letting me talk. My last point is the case management agencies. I'm wondering how this expansion is, they are going to deal with this expansion. It took us 17 months to get on the waiver after we started the process. Once we were on the waiver, the first year that we were on the waiver, we had 10 case managers switched out because of all the turnover. And I don't, you know, I don't know. And I want to be clear too, like I fully support kids with mental health issues getting waiver services and support too. But I don't know, and I don't know that I have a lot of solutions, but I just wanted to give examples of concerns that parents are going to be having. And I'll leave it there. Thanks for letting me talk.
Thanks for sharing your experiences, Terry. It's helpful to get a parent perspective in here, and a lot of what we hear is from the advocates or provider agencies. So appreciate you taking the time to share your experiences. Other folks, concerns from a perspective that you've had. If anybody has looked through the released budget, we are certainly in a tight budget time, and so I absolutely hear you that increase rates, rate parity, all of that is really important and really necessary. But I think we're going to have to get a little more creative in how we might be able to recruit and incentivize providers when we are not going to necessarily be able to increase those rates. So any thoughts on that? I see Megan, you've got your hand raised. You can go ahead.
Yeah, I mean, it ultimately goes back to like basic supply and demand, right? Is what we're running into at a lot of these issues, that if we increase the demand by increasing eligibility and access, that's awesome. We love increasing eligibility and access to people that really need the services. But if we're increasing the demand and we don't increase the supply of providers at all, then we've really stripped out and made, and our efforts to increase the access are fairly worthless, because they don't actually expand access if there aren't providers. You've just taken this pool of providers and spread them out over a lot more people. So now we've got new people and old people that have less access, even though our intent was to give more access. So we know budgets are tight, and I do not envy that sort of piece of it. But I think what had been articulated before and needs to continue being articulated is that if we don't make some real strides in increasing the workforce, then any expansion doesn't actually expand anything, and it's just looks good on paper, but it's not actually meeting the need. My 4 cents.
Thanks, Megan. I appreciate that. And I mean, we all very much agree. We certainly don't want to take the exact same amount of beds and say, here, just you have to serve more kids like that. The numbers aren't going to lie. But we are hopeful that efforts to increase provider access, expand to new providers. We do have a negotiated rate when it comes to the residential service. That has been helpful in trying to meet providers where they are and paying providers to meet what it costs to serve a child. So that has been helpful in trying to serve more kids. But I see we've got Pam, if you want to go ahead.
So again, from a provider perspective, who's currently not working with the CHRP population, right? But kind of ears peaked to what does this SCD definition mean? And reading it kind of in black and white, it seems like it is our current population, right? Whether they're on Medicaid or in our QRTP or in our respite. And those kids are already receiving Medicaid services. And just as Maureen had explained, on the side of non-CHRP kids, we have the same rate issues. Some of us have closed some community and WRAP services because we can't afford to do it. So I guess I'm confused as to what is the difference, because the kids are with us now, they're on Medicaid. Is this CHRP waiver expansion going to give more money and resources, even though they're kind of already under HCPF's tutelage? I'm confused as to where the path is going now, what it actually means in implementation.
It's a good question, Pam. And you are right that a lot of these children are already being served. So it's not like this is a brand new population that is coming onto Medicaid, coming into services. A lot of this is there's going to be crossover. So they might already be residing in a QRTP or receiving wraparound services. What this does is it's allowing access to a new set of services that they wouldn't all have access to now. If they're getting all of those state plan benefits, it's providing access to those additional waivered services under the CHRP waiver. That's the big thing. And I think when it comes to residential services, we'll just see a shift, even though it's Medicaid, it's the payer within Medicaid, we'll see kind of some shift of how that is specifically funded. So it would be folks who it would be being paid under the waiver now rather than out of state plan funding. And as Maureen put, that if parents are over income, they would not necessarily the child would not qualify to get services under state plan. But if they are over income, they could potentially qualify to get services under the waiver. So I think there is some kids who would be new that are not getting services that would be able to get under the waiver. There's some kids that will be already receiving services and treatment. And then you have your existing CHRP population. So I think we're not anticipating a huge explosion of kids accessing this waiver, but there will be a minimal increase.
So then for those of us like in res at a QRTP where these kids might fit right now, like our current kids might fit this waiver, then do we have to become a CHRP provider to do that? Or is it just accessing different funds to help pay for if that kid fit that mold and definition?
So it will depend on if they continue to stay and receive residential services there. I may punt this over to Nancy. Nancy, if you might be able to help answer a little bit about the residential options and whether those kids could continue to remain, if you could speak to that.
I'm not real sure if I have a clear answer either. But certainly right now, kids that are in QRTPs aren't typically in CHRP. So I'm not saying they would have to move because that may be the best placement for them at this time. But we would be looking at probably RCCFs rather than QRTPs, and whether or not we have the availability to provide services for those kids, you know, if there's openings, basically is what we're looking at. So each individual case would look different, but if you're asking about other services that could be used, I think we need to definitely look at that because we need to know what exactly their plan looks like. And I think with CDHS and certainly I'm, you know, not the most knowledgeable in this area for QRTPs. That's not my knowledge base, but certainly looking at what that looks like. Do you have the choice to move from like an RCCF to our QRTP or vice versa? I'm not sure what that looks like through CDHS, and that's something they would need to answer. So I'm not sure I answered your question.
So now I'm even more confused. Then what for the SCD waiver? Who defines the youth, right? Because as I'm looking again in the chat around the definition, that's like 100% of our kids in QRTP right now. They meet those three criteria. So what's a CHRP SCD waiver kid and what's not when that definition is pretty similar, especially that's a definition that's, you know, you need to have a diagnosis to get into a QRTP. So I guess, and maybe this is just being all flushed out, but and maybe it can't be answered now,
but a child doesn't have to go, like, the thing is they could continue to receive services through the state plan exactly as they are. They don't have to move on to the waiver. There is no requirement that they come over and move services over here. They move out of a QRTP. They don't have to do any of that. There is just an option that if this set of services, or they're not otherwise eligible to receive Medicaid services, then maybe the CHRP waiver is the solution for them. If this set of services is something that they're seeking that would be helpful for them, then they could try and get on the waiver. Otherwise, they could remain over here. We can have two sets of populations running parallel with similar sets of services. So I think that's a confusion, is you don't have to switch. It's just two types of options for eligibility. Shannon, you've got your hand raised. Go ahead.
Thank you. And I was late, I will concede that. So if you guys have addressed this, you can cut me off. But I do have something after. I have two things. So the first thing is, I know we're talking about CHRP and again, thinking about SED and expanding. I guess for me, I look at the bigger things that are moving within healthcare policy and financing and all of the shifts, and with case management redesign and the new CMAs, and we've got community first choice, right? We got lots and lots of things going on. One of the things that has come on the radar though lately is that, you know, with the new bill, and as you say, with the joint budget committee and all those things, that they're looking to, you know, cut funds for behavior therapy, right? And so I'm looking at the numbers. It says he's proposed a 19.5 million cut to pediatric behavioral health PBT services. So again, we're thinking that bigger picture, right? Not just CHRP, but if we have kids that are coming onto CHRP and we're getting budget cuts, right? And we're not even either staying steady, or we're now reducing rates for behavior providers, that at least tangentially has to affect CHRP kids, right? Possibly. You think even about just state plan kids, you know, as you were saying, it doesn't have to be one or the other. If we're looking at cuts for behavior therapy, it could affect our kids as well. So I just want to throw that out there as a caution, that when we talk about expanding eligibility, as Maureen and everyone else has said, you can expand the, or even, I don't know if it was Megan, you can, you know, expand the pool, but if we're cutting services or cutting providers, or cutting rates, that tangentially still affects the implementation. I'd also like to echo as a parent, my child started on the CES waiver, now is on the SLS. We've moved into that adult world. The problems didn't change, right? We still have those extreme behaviors. We still have the lack of providers. We still have whatever. We never did get on CHRP. We never got a host home. We never got any of the things that, you know, we wanted when we were eligible as a youth. I just want to echo the concern that we now have a respite provider. She has literally gotten her butt kicked. I mean, we're talking her butt kicked, right? Because he's got some pretty extreme behaviors. And I think that's what we need to think about is, I know Terry said that's not how her daughter manifests. There are those of us who are maybe the outliers that is the case. And so we need to think about what are the options for those kids that are the extreme cases, right? When you have somebody who they're getting their butt kicked, what do we do to keep those people? Because she keeps coming back. And if she didn't keep coming back, I don't know what I would do. And I'm genuinely sincere when I say that. Because I've only ever had one respite provider in 6 years, one, and she keeps coming back. And so what do we do to keep those folks in the workforce and recruit and retain? Because there are the outliers. So I just want to throw that out there from a parent perspective, that we need to think about the extreme cases. I know we're on the opposite end of the bell curve, but there are a lot of kids out there, and that's what the CHRP waiver is designed for, is that spectrum of kids, right? That may need an out of home, that may need those extra services with the extremities, right? So I just want to throw that out there to think about us. Thank you.
Thank you, Shannon. I think you echoed a lot of what Megan had to say about really needing to make sure we have a solid workforce. So thank you. And thanks for sharing your experiences. Maureen, you've got your hand up again.
Yeah, thanks, Shannon. I totally appreciate what you said. I think that there's an assumption, and maybe it's just because we have the residential and the CHRP acronym, that most of these kids are in residential. And we don't have enough beds for that to happen. So I think that's the other thing that is important with the suggestions I made earlier, is that we're not going to have enough bed capacity for all these new enrollees. And we need to really, build up and strengthen and support, because those workers, like Shannon said, and also Terry said, they are going to get beat up, and they need to be W-2 workers. My son broke an arm of one of our providers. And had she not been a W-2 worker, she didn't have her own health insurance. This was years and years ago. So, I mean, I think it's really, really important that we realize that we can't get away with the same low rates that we might in the other children's waivers for this. Is there a chance that anyone on the call from HCPF could give us a breakdown of the current CHRP members, the total number of CHRP members, and how many are in out-of-home placements and how many are in home placements? Because I think that might break this myth a little bit, just to give us some perspective.
Nancy, do we track that?
No, I don't specifically. But I'm sure through reports, through utilization and so forth, we could probably get some of those numbers.
Well, maybe you can tell us how many RCCF beds are there in Colorado and QRTP beds. That might give people a little perspective too.
I think those
Well,
are
I can't.
fair
Go ahead.
points, Maureen. I just don't know that we have those off the top of our heads
Yeah.
and can pull those in a matter
Okay.
of couple minutes.
Maybe we could get that posted on the site somewhere. I think that we're just over 200 enrollees. Last time I did an open records request, I think there were 239 youth on the CHRP waiver. Don't know if that's still accurate, but we're not talking a big number. But I predict, I mean, I don't know if you all have done projections, but I think we're going to get 2,000 kids eventually on this waiver through the SED expansion. So we've really got to figure out how to support these individuals in the home, because we know what the safety net is for kids who don't get the appropriate support interventions for behavior. And what is that safety net? I'm going to give a pause because I'm a teacher at heart. It's called the correction system. If we don't get these interventions early, these kids end up in correctional facilities known as prisons. It's the disability to prison pipeline. So I really, really can't stress this enough. And when I have my conversations with legislators, and I encourage everyone here, that we need to make that clear, that investing another $1, $2, or $3 in an hourly rate, it's a very good investment versus paying $200,000 a year for being in jail. So anyway, sorry, just my little soapbox.
We've got about 14 minutes left. Are there other folks that would like to share their thoughts, concerns, experiences?
There was a comment in the chat about the ICAP assessment, and if that's the plan for HCPF to continue using. It was Victoria Kennedy, and I agree with her that the ICAP sucks. I trained in it. I also did the high fidelity wraparound training myself, and it's outdated. It's archaic. So I'm just wondering. I believe in one of the meetings I went to, they said that they might adapt it a little bit to update it. It talks about phones on the walls in one of the questions. We don't have phones on the walls anymore. So anyway, and remembering phone numbers, that was the other one. Thanks.
We do plan to use the ICAP. We are looking to continue to use that for this. I know it's not ideal, but it's what we have available to us in terms of that assessment. We plan to, I know there was talk, Shannon, I think you mentioned about case management capacity, their ability to get folks on. We are in the process of revamping training. I know that this sometimes falls on deaf ears, but we're certainly trying to give case managers the tools to understand how this population can be served under the expansion. Because I think generally, we're trying to improve access and awareness about the CHRP waiver. So just really trying to push that in conjunction with this expansion, trying to figure out how exactly to get eligibility worked. We're looking at utilizing, in addition to the PMIP, a attestation form that a physician can fill out that says this child does have a serious emotional disturbance and it impacts their activities of daily living, basically. So getting that just to help those case managers so they don't have to sit there and try and figure out, does this qualify, does this not? But they get that physician form to kind of help with that. So hopefully that helps answer your question, Maria. I do see we have a hand raised, but I can't say who it is.
I've got my hand raised, Cassandra. This is Hani Rayleigh with the Arc of Aurora.
Yeah, please, thanks.
I appreciate the effort and energy to make sure that Colorado kids are served in a manner most appropriate. I do think, however, as you continue to develop what this process looks like, what the kind of recruiting modules look like, what the training, all of the pieces that are going to actually make this important on top of the rate structure, really looking at how we can differentiate the training and expectations across the audience of kiddos that you're looking at. the habilitative model is not always the best model for kiddos with IDD already. And I think that it's important for us to consider when we make a waiver larger, let's say, and expand the criteria for entrance into the waiver, how that might be approached by service providers in a way that might be not culturally competent for kiddos with IDD across Colorado to be managed in the same way that some of the SED kids are as well. I would argue from an advocacy perspective, I'm not real sure that that methodology is great for SED kids either, but that's not my category of folks that we support. But I really think that while this has lots of opportunity to support and kind of build some opportunity within either the community-based settings or more residential-like settings, that we've got to make sure that kiddos are getting truly what they need and that we don't apply some basic Band-Aid across this audience of kiddos that's really going to undermine really progress and community living that we're hopeful for as they transition into adulthood. So I think we would really be failing kids if we miss the chance to differentiate training expectations, documentation expectations, and what habilitative truly looks like for kiddos in Colorado.
For that. So let's see, I saw a couple of questions about next steps and kind of what you all can do. I think we will collect the comments and the questions that we didn't answer in the chat. We'll work on a listening log that can help kind of with those questions. I don't know that there's a plan for a second meeting, but we're continuing to, we'll have to see, Maureen, work through the implementation of this. As Maureen did say, this is a legislative mandate. We are told we need to put this criteria into this waiver. So that is what we are trying to do and trying to kind of make the best here. So we will work on answering your questions. We will work on collecting kind of feedback from you all on the best way for implementation, and getting things implemented with case managers in terms of training. We're looking early spring, so probably March as an implementation date. But I think, the number one thing that you all can do is, if the concern is that the rates need to be increased, I would encourage you all to advocate for that. The department has put forward the budget. The budget is very tight and there's a lot of shortfalls across the state. But I think hearing from you all as parents and advocates, explaining why these rates need to be not only sustained, but increased, that this population is unique, requires a higher skill set of services, dedicated staff that can take getting their butts kicked, as Shannon said. I think that's something that we really need you all to take to the legislature and let them know. Share your experiences, share your concerns. That's going to be the best hope that we have of seeing any changes to these rates. I absolutely hear you, Maureen, that a lawsuit's going to cost a lot more. I agree with MPRAC is probably not the best way to make these changes. I think it's really talking to your legislators and encouraging and explaining why these rates need to be increased. So I think that's the number one thing that you all can do in the interim is push for that. I will ask, again, if there's any, I don't have a lot of answers today, really just looking to listen to you all, but if there are other questions that you'd like to raise that we can take back, or any other feedback you'd like us to hear today, we have a couple minutes left. Shannon.
So I have probably an ignorant question, and again, I'll at least beg that I was late to the show. Maybe you talked about this a little bit, but again, I always think about the fiscal piece, right? The fiscal responsibility, and I know I've said this for many years, the pie is only so big, right? So we have to be cognizant of where the funds go. And so we often rob Peter to pay Paul, right? And I don't know where we do that shift in funding. I guess I just think with such a tight budget, and again, thinking that if there really is going to be even this $19 million, budget cut to behavior therapy, right? Pediatric behavior therapy. Has the department considered, again, like what it looks like? And maybe this is like a rhetorical, bigger question, but thinking about, again, what would it actually take to provide the pay and the stability and the services that are necessary, and at least doing a gaps analysis, right? Doing that comparison. And I don't know if the district, see, I'm thinking schools. I don't know if the department has done that. But even something like that to consider, so that even internally, you guys would have a sense of, this is what it would look like fiscally. And then you could go, do we rob Peter to pay Paul, or do we ask for more money, or do we look for shifts, or what does that look like? So I don't know if you can speak to that, or if you just go, yeah, we haven't done that.
No, Shannon, those are good questions. And yes, we have. So for all of the services that are provided, our rates team develops a rate based on lots of factors: overhead costs, facility-based costs, looking a lot of the Bureau of Labor and Statistics, all the things that what it takes to provide the service. And then they come up with what that rate is. And then often we go, that's way more than what we actually have money for. So we apply the budget neutrality factor, which basically says, what does the rate need to be in order to serve the amount of people that we're projecting with the amount of money that we're appropriated? And that budget neutrality factor, that percentage that we apply that says you need to shrink what that rate is, it varies across the services. And that's one of the areas that we've always tried to focus on in terms of suggesting rate increases. Hey, this has a very high budget neutrality factor, but we do know there is a pretty, depending on the service, there can be a pretty big gap between what we really should be paying and what we can pay. If we were to fully fund all of those services, it would be lots and lots and lots and lots of money. But even just a couple of these services, when you're talking about what it would cost to fully fund respite or youth mentorship, even that, it's still pretty high. So we do know what we should be paying, what we could be paying versus what we do pay. So we do have all of that information. And it's just, like you said, the pie is only so big. And so then it just becomes, what do you sacrifice in order to increase something? Anything else? I'm seeing a couple of chats come in.
May I just actually, looking at the comment, I guess maybe that's more where I was going to. Not just have you looked at the budget, have you looked for either innovation or, and I hate that word too, because innovating is whatever, but thinking about places where there could be a shift or where there could be new ways of doing things, or cutting, again, not rates, but overhead or provider burden, right? We think of provider burden, all of those kind of.
Yeah, absolutely. I mean, I think that's very much where we're at this point of how can we possibly get providers to participate and not be able to offer them more money. And so definitely trying to think creatively in terms of, I think that's a lot of what the workforce team is trying to do. Are there other ways, other benefits that we can incentivize workers with aside from just a higher wage? So definitely trying to look at those things as well. Thanks, Shannon. Well, thank you all for your participation today, for your thoughtfulness and in bringing us your feedback in terms of what we could be doing better differently on the CHRP waiver, where we need to focus our attention. If we could wave our magic wand and put money toward rates, which rates really need to be increased. So it's helpful to hear from you all that it's not just, because where we hear a lot is the residential rate is not enough. So it's really helpful to hear that it's not just that, it's the respite rate, the mentorship rate, that's not high enough for that skill level. So really appreciate you sharing your feedback with us today. We'll work on a listening log and getting that shared. We can share some, hopefully the numbers aren't too small that we can share where folks are utilizing the services across the state and the number of CHRP members. So hopefully we can share most of that. But with Safe Harbor, we can't share too small of numbers. But I think we should have enough numbers for those residential placements that we can share that out. So please look for that. And thank you again for your participation on this election day, everybody. Take care.
Thanks, Cassandra.